Good morning, everybody, and thank you for being here today. We are Vestia Consulting Group, and we are here today to discuss our program to improve the health of individuals who are homeless residing in Hennepin County, Minnesota. My name is Natalie, and I am here with my colleagues Christine, Uzma, and Monica, who will assist in today's discussion surrounding the system, financial, and community aspects of our proposed solution. Today, we are asking for your buy-in to implement our solution, the LABRA project, which encompasses the use of telehealth kiosks, interprofessional teams, and community engagement in order to connect individuals who are experiencing homelessness to the resources that they need in an efficient, accessible, and sustainable manner. To begin today's presentation, we will first present the current problem. We will then introduce our solution, the LABRA project. We will then discuss how our solution can have a greater impact on the Hennepin County community. And finally, we will discuss the cost and savings associated with our program. To begin today's discussion, I would like us to take a step back to view the current trends of individuals who are experiencing homelessness within Hennepin County. Although there was a steady decline in those experiencing homelessness between 2012 and 2015, the most recent reports has demonstrated that the number of individuals experiencing homelessness continues to rise, with the most recent report demonstrating an increase of almost 3,000 individuals between 2017 and 2018. Action needs to be taken now in order to disrupt this vicious cycle of chronic, untreated, biopsychosocial conditions that this community face, and to prevent cities within Minnesota from down-spiraling. And the question I would like to pose to this group today is this the image you want people to think of when they come and visit a city within Minnesota? In Hennepin County, the effects of these rising trends are quite evident, with approximately 50% of those who are experiencing homelessness within the state residing in Hennepin County. Of those experiencing homelessness, approximately 83% have either a physical or mental health condition, whether that be a chronic health issue, substance abuse, or past traumatic brain injury. Also, of those experiencing homelessness, approximately 44% have more than one chronic health issue. To gain further insight into this problem, I would like to introduce you all to three individuals who experienced this problem firsthand in order to gain better insight into this chronic public health problem. First, I would like to introduce you to Abe. Abe has experienced homelessness for the past 10 years and suffers from both depression and poor oral hygiene. This has resulted in Abe to experience the loss of his front teeth, which makes it difficult for him to secure a job and to pull himself out of this vicious cycle of chronic homelessness and poor health. Next, I would like to introduce you to Cody. Cody suffers from both a bipolar disorder and substance abuse. Cody also suffers from asthma, but does not currently take his asthma control inhaler, which causes him to suffer from severe asthma attacks, which often result in him ending up in the emergency room. And finally, I would like to introduce you to Erica. Erica is a 30-year-old mother of a 15-year-old daughter. Erica has a learning disability and also has a history of past trauma and abuse. Erica does have a part-time job, but does not cover the cost to afford her own apartment. She is on a wait list for subsidized housing, but that wait list is over 9 months long. Because of her learning disability, Erica just wishes that she had somebody who could go and help her navigate the system in order for her to break free of this vicious cycle of chronic homelessness. After reviewing each of these three cases, the team identified common needs that each of these three individuals shared. Even though each of these individuals came from different backgrounds and circumstances, each lacked some form of a support system, needed some form of mental health support, had difficulty navigating the system, and had difficulty accessing the resources that they needed. It was with this understanding that the team began to ask ourselves why this was happening in order to identify the root causes that were contributing to this public health problem. As you can see by our fishbone diagram, the team identified 4 categories of issues that we thought were contributing to this vicious cycle of chronic, untreated biopsychosocial conditions that this homeless community faces. As you guys can see, This diagram is very complex and cannot be just addressed through one program alone. So because of this, the team decided to first identify the people and procedures involved in order to create a program that best addressed these root causes.
There are so many resources already available in the city of Minneapolis, but why are we unable to connect them to the people who need them the most? It's because these resources are not easily accessible, forcing individuals with homelessness to find solutions by themselves. The LABRA project proposes simplification of the system by implementing kiosks throughout the city of Minneapolis to provide a wider variety of resources and health care. Now, the Kiosk 1.0 is a readily accessible database that connects users to nearby resources that best fit their most immediate and specific needs. It will be available in multiple languages and will include assistive technologies for those with disabilities. The kiosk will use geolocation to pinpoint nearby resources and will be dispersed throughout the city on buses, in grocery stores, and in highly populated homeless communities. These kiosks provide a personalized approach that provides a wider variety of resources and health and data that our homeless community may not yet be aware of. Now, let's take these kiosks to the next level. The Kiosk 2.0 is a soundproof, confidential, HIPAA-compliant telehealth booth that will be dispersed strategically in highly populated homeless communities. It will be available 24/7 and will provide services such as chronic care management, dental hygiene screenings, and mental health services. The Kiosk 2.0 uses an interprofessional approach. Healthcare professional students, residents of interprofessional teams, and contracted healthcare providers will be able to use this telehealth booth to provide chronic care management and early preventative health screenings. Caseworkers will be hired and placed at each kiosk to build trust, to provide relationship-centered care, and to assist with the logistical workings of the technology. These kiosks will be able to screen patients to determine their chief complaint and to connect them to the healthcare professional who can best address their needs. Now, if a patient comes in with mental health concerns, they will then be connected to a mental health behavioral specialist. If a patient comes in needing a refill on their mental health, diabetes, or hypertension medications, they will then be connected to a provider who can best provide them with this refill. Caseworkers and students will then ensure that any necessary follow-up appointments are made either at the nearest healthcare facility or at these telehealth booths to ensure continuity of care. This interprofessional approach ensures that a better holistic therapeutic solution is provided, and it utilizes the skills and expertise that each profession has to offer. Now, let's go back to our three friends. Abe will be able to use our kiosks to receive more accessible direct patient care so that he can improve his health, increase his self-motivation, and increase his self-confidence in order to obtain the skills needed to secure a sustainable job. Now, Cody, our resourceful client, will be able to optimize his use of these resources and maximize the benefits that he can receive. Through our Kiosk 2.0, he will no longer have to worry about being without an inhaler because he will have an increased access to chronic care management to reduce his hospitalizations and to receive the care that he should receive. Now, Erica will finally be able to navigate the system. Through our kiosks, she will be able to obtain the skills needed to manage her finances and to utilize the resources so that she can receive all the benefits that she can receive throughout the resources that are currently available in the city of Minneapolis. The LABRA project ensures continuity of care and utilizes an interprofessional approach to provide the best care for our patients. We streamline the use of resources by bringing these resources to the community, and we coordinate system navigation in order to increase job and housing opportunities. With your help, the LABRA project will effectively disrupt the vicious cycle of chronic, untreated biopsychosocial conditions and allow our users to create a more healthy, balanced, and sustainable life for themselves.
Our kiosk program involves the viewpoints and perspectives of various stakeholders, such as the public, institutions, the health providers, the homeless population, and the private institutions as well. So how do we kickstart our program? Our main goal is reestablishment of the homeless population back into the community. We begin by generating funding from like-minded stakeholders, such as grants and Fortune 500 companies. We then take an input from, the frontline staff and to fill in gaps in our system. We then use this feedback to deploy our kiosks into strategic locations, such as the Metro Rail and Walmart. Using that, we deploy our students and our caseworkers into the community so that there is increased usage and they can educate the community about using our kiosks. Through these services, we would facilitate the integration of the homeless population back into society. Now, how do we get the community involved? We do this in 4 steps. We begin by developing programs to train our municipal employees, students, and caseworkers. We then establish relationships with peer support groups so that we give our population the social support it desperately needs. We know that the healthcare system can be uncertain. So in order to provide stability, we utilize involvement of policy makers such as the Senate and the Congress. And then we employ crowdsourcing. We try to create a system that is for the locals, by the locals. All right, so now we measure 2 factors of success, the first being resource utilization. We saw that bottleneck of resources creates a strain on current resources, so we plan on streamlining it to other resources. For example, the ED department has visits highest from the mental health and substance use screenings. Through our Kiosk 2.0 services, the ED department will be more efficient in their usage and functioning. We then have community involvement. Community involvement would be increased investment in our programs and just very engaging and involvement of everyone for the success of our program. So we realized there is a lot of risks involved in implementing our system, and we identified 4 factors which we would measure success and learn from the current needs and demands. That would be stakeholder involvement, increased stakeholder involvement and investment in our programs, savings financially, such as ER costs, and then we would focus also on our products and services. We would measure in months how our kiosks were doing and improve accordingly. And then we would also, community involvement and satisfaction is extreme importance to us. So we would use end-of-service surveys to see where we're going. Our main impact is to navigate and provide healthcare reductions, costs, and prevent relapse of diseases. We want to focus on population that hasn't already been reached. For example, people coming out of corrective facilities, they would use our systems to get back into society with the resources that they need to integrate and rehabilitate. Here's how our kiosk would look like. We plan to amass a network of services that our clients can reach through one system. We simply plan on providing a pathway to success. Our major employment and food providing programs as well. It's not just healthcare. We are simply providing shoes to an already resilient population. Through our services and navigation, we just plan to increase importance and priority of a population that needs its chronic healthcare and homelessness needs met. Thank you.
How much does our solution cost? We did our research and our due diligence, and would you believe me if I told you it's less than $600 a person? Hard to believe, right? And what's beautiful about our solution is that it includes everybody. It's able to be less than $600 a person because you only need a 6th grade reading literacy level to be able to use our highly visual graphic user interface that's going to be available in multiple languages and have assistive technologies embedded in it. It's going to be mounted in highly populated areas such as metros, buses, towns, grocery stores, libraries. And what that does is that the community engagement and stakeholder that we keep talking about, what that means is people who are stably homed, at risk of losing their homes, and currently unhomed will be able to use these resources. Let's talk about Cody. He's 25 years old, has a lot of years left of his life, right, if he doesn't keep going to the ER. Cody might use the ER up to 4 times a year, and that can cost the taxpayer up to $66,000 every year because he doesn't have a controller inhaler, right? It got stolen, and so he relies on a rescue inhaler. How do we prevent that? He's really resourceful. He knows how to go to the library and surf the web. Let's meet him where he is. He's very headstrong, has a strong spirit. Let's meet him where he is. So these kiosks are really easy to use, and if he sleeps on a train, he can pop and check in with his healthcare provider and get that refill on the controller inhaler that he needs. Get him out of the ER. Users like Cody cost the taxpayer up to $66,000. Someone like Erica may not need to use the ER as much, so us being the conservative consultant group that we are, say, let's bump it down to an average saving of $30,000 a year. That plus less than 10%, according to the Wilder Foundation, of 9,000 users who are possibly homeless on any given night, at least 9,000. Let's just take 700 of them in a given year. So 700 people that we know are unstably housed, plus let's say another 700 people in Hennepin County who are at risk of losing their housing or stably homed and take public transportation. You multiply that all together, and at minimum a $46 million saving of preventable upstream care management solutions are available for us. I think that's beautiful. It includes everybody, people who are stably housed and currently don't have stable housing. I have also included on the left-hand side comparable initiatives, and I just want to show you that these solutions are also beautiful, but what we do better is it's more inclusive. It captures more people who have been falling through the cracks for a really long time in America. So how do we roll out our plan? In year 1, I'm a big believer in harvesting hard data. I believe in harvesting data. So we're going to do that with our kiosks. It's going to have geolocation. It's going to be connected to the internet. We'll be able to track usage, utility, satisfaction all in the first year. And that's going to increase the robustness of what we're doing and help guide the direction that we're actually implementing our solutions in. In the second year, I'd also like to engage calibration of stakeholders, right? Engaging healthcare providers at every level and making sure that our users are getting triaged appropriately for the level of care that they need. In year 3, I want to start engaging a smartphone app that anyone who has a smartphone can directly donate and crowdsource funds to our initiatives, as well as engaging some corporate stakeholders as well. Minneapolis has so many Fortune 500 companies. Can we get them to have an investment in our local community? There are a lot of wins here for both sides, right? We have United, we have Best Buy, and we have Target at headquarters here. Let's get those folks on board. In year 4, after we have enough data and evidence to support that what we're doing has long-term sustainable outcomes that are beneficial for everybody in the population, let's get some policy changes to help make sure that the people who fall through the cracks don't keep falling through the cracks. In year 5, all those policy changes also means that our kiosks have to change too. They have to evolve. Can our kiosks be listed addresses for perhaps prescriptions or immediate needs to be dropped off at, so folks who don't have a stable house location can still get the needs met? That's what our 5-year plan looks like. So we threw a lot at you. It's very synergistic, it's interprofessional. And I want to talk about our core values that are reflected here. Right? We have interprofessionalism. We have relationship-based care that's patient-centered. We have best practices. This free flow of information in our interpretation is taking the internet and really putting the power into the hands of the people who need them most. It's culturally sensitive and competent, right? We have a lot of people who come to Minneapolis for land of opportunity. We have a lot of languages that are being used. Can they be incorporated into our kiosks? Okay? I like to bring my colleagues up here and say that are you ready to invest with Bestia? Are you ready for best practice, evidence-based, a robust solution that's highly mobile, has a low overhead, and has infinite scalability? Thank you for your time, and we're ready to take your questions.
I'm just wondering, I appreciate the sensitivity to the homeless and also the sensitivity to you connecting to existing services rather than creating more and new services. I'm just wondering, what do you think realistically is the willingness of the different services that you're talking about connecting with to actually being a part of this and connecting, and how do we know that?
Well, in one of the resources that was provided, we found about a 50-page long handbook of resources that was divided up by whether they need healthcare, food, clothing, housing, and it was a very organized list of the addresses, phone numbers, and different locations that did that. So essentially, we know that those resources and community organizations are out there and are currently trying their best to go and connect these individuals with these resources. So essentially, what we're doing is we just saw that there was a disconnect between how they can go and engage those resources. So essentially, the kiosk is just taking these resources that are already out there and they've already made the voice known that they are willing to help this population, and we're just going to take it a step further so it's more accessible for them. If that answers your question, or I could further elaborate a little bit more.
I think it does. I think, and I appreciate that you're kind of taking the middleman out of it. Is like the homeless person, can go to this kiosk and interface with the services that I need. I don't have to go to a homeless shelter to access the services.
Yes.
Is that?
Yes.
Okay. Absolutely.
Thank you.
Thank you for your presentation. I may have missed this, but how many kiosks do you plan on rolling out in the first year, and how do you okay, got it. So can you just explain a little bit more between the staffing that's going to be at the kiosk with the kiosks, and where does kind of the internet and the interface of the kiosk somehow coincide with like the human experience and the caseworker and making those connections?
I love that you asked this question because we left some breadcrumbs along for you to ask this. So we have 4 total kiosks. We have the 1.0 that is like a mounted tablet, right? And then we have the 2.0 that's like a real booth for HIPAA compliant reasons, right? So we have 3 1.0 kiosks and then 1 2.0 kiosk. And this 2.0 kiosk, because it costs substantially more, will be placed in an area that has a lot more people in it. Ideally, a homeless community, perhaps a temp town, right? The 1.0 kiosk, we're hoping for folks like Cody or folks who are able to use transportation as their primary domicile, would be mounted on a metro, for instance. So the students and the caseworkers, when we need a very strong first impression. And just because we plop something down in the middle of nowhere doesn't mean that you'll get users to pick up on it. So especially within that first year when I was talking about harvesting data, we really need boots on the ground so we can build face-to-face engagement. Our solution here is to create an honors course elective in a health professional curriculum that is going to be appointed with faculty. And at least at our school, we have something called SHAC, which is where student volunteers do intake or screening and helping students triage. So if it's a year-long course, you have a year to at least start to build a relationship with someone. It's like, how do I use this tablet? How do I use this kiosk? How is it going to help me? Having them kind of push people in, having caseworkers who can build, this is someone who's going to actually help me. And we know that a year is not a very long time, but I think it's long enough to get some initial trust building for the referral and the services that are needed. Does that answer your question? Great.
No. Thank you very much for your presentation. My question was a bit similar. I was interested in the beginning stage of your rollout, and what ideas do you have about sort of testing proof of concept? Because, okay, three kiosks through 1.0 and 1 for the 2.0 doesn't seem like a lot. I first had the impression that you would have many more without sort of data to support usability and sort of the relevance of the information that you have in the kiosk. So can you talk about how you would approach sort of testing this out first and proof of concept before a larger rollout, and the role of people who would be using the service in the design and implementation?
That's a multi-layered cake question. So let me try to break it down. So my understanding is that in terms of deciding why we chose the numbers that we did being fairly low, and then the second part being how is it actually going to happen, right? In terms of like the different entities and making sure that this proof of concept actually happens.
The first part is how would you sort of test the idea to make sure that it is feasible and people will actually use the kiosks to begin with?
So how we would do that is we would focus on certain communities and the areas, the healthcare facilities around them. So like we would measure like how many ED visits they have, the frequency of ED visits, and whether they've reduced or not through our kiosk services. We would see if there's greater enrollment in government programs in that particular area and see how the census rolls out on that. We do realize that there are like 10-year reports and like 2-year reports of people using current services, and we would rely on those reports to see whether it's having an impact on the community or not in that particular area.
And by building on the outcome measures that Usma just stated, in our 5-year plan, we do plan to hopefully deploy more kiosk 1.0s and 2.0s. So by year 3, we would like to add more kiosk 1.0. So the monitor on a stand on to more buses, maybe grocery stores, homeless shelters, and then hopefully by the grants that we apply for in year 1, we'll be able to get a more sustainable source of income so that we can provide more kiosk 2.0s.
Yes. Yeah. And going way into the future, we would also have like surveys in which we have information of the people, and we would like make our system more HIPAA compliant so that we have data that we can refer back to improve our services and see where we can expand.
So this is just for year 1, or this would be projected out, or what's this breakdown of cost benefit?
This is
This
year
is
1.
year 1.
Yeah, this is year 1.
Okay. And for the case manager cost at 35, is that including benefits, or is that all in?
Benefits for the caseworker?
Yes.
These numbers were taken directly from the Heading Home Hennepin report, and each caseworker was paid $35,000, and it didn't include whether the caseworkers had a benefits package, although I personally believe in rewarding people for the work that they do. So, yeah. So it's a lot, right?
Yeah.
But that was what the report had, and so those were the numbers that we used.
Can you tell me, is this being done anyplace else in the world?
So actually, we just found an article on CNN this morning where they actually built a tiny home community, and they have like a microcosmic mini version of this where they have mini infrastructures. And while it's not truly in the form of a tablet kiosk version, they do have chronic care management services in what is like a rental leasing office of a tiny home community. And so I see some prototypes emerging, but in terms of the leanness, the low overhead, and highly mobile aspect of it, I haven't really quite seen it yet.
Yeah.
Have you?
I know that like in the version of the kiosk 2.0, there has been certain institutions like Publix who have been willing to go and put a couple in like local community pharmacies, so just like CVS or Walgreens, but those are just the 2.0. But the aspect that it doesn't include, because it's just telehealth services, and that's all that's required, like encompassed in those booths. However, but with our kiosks, we have that additional geolocation of resources that will be included in both of those. So it's still like a fairly new concept, but ours kind of builds upon the newness that has been already put out there.
Right, the real-time analytics, uploading that information. You know, if a nonprofit decides to change their services, we need to make sure that the people who are receiving the information have an up-to-date, book. A paper book can be out of phase within as little as 6 months, depending on funding changes. And so that's the nice thing about having things that are internet-based. You can have a software programmer who uploads or changes code as needed. And that's also the nice thing about having corporate investors who also say, you know what, let's be a preferred provider that invests in this, so we can also drop their services and pinpoint on our little maps for referrals that are closest to them.
You talked about community engagement, and I'm wondering if you could tell us a little bit more about how you would engage the community in the development of the kiosks, specifically the users, because I think about sort of cultural issues and groups that may be more relational and not want to engage in technology. This is not going to be useful for them. And also literacy. You said 6th grade reading level?
Right. With assistive technologies, right? And so we have a lot of people who come to Hennepin County as refugees, right? And so I completely agree. And that's what the caseworkers who will have their boots on the ground, that's where the university students at Interprofessionals will be able to do the screenings and intakes. And sometimes the users themselves can be the students who help folks fill out the forms. Not everyone will be able to fill out the forms directly, but and I would suggest to you that in comparison, it is much harder for someone who doesn't know the infrastructural systems of America to get to a clinical office that can get this. So we're bringing the resources to them, but I agree that in order for the integration to happen, we definitely need boots on the ground. That's what we're hoping the students, through an honors core curriculum as an elective, as well as caseworkers and faculties kind of overseeing the calibration of students will be really important, at least for year 1. We also have an aspect of community engagement in year 3 as well.
Maybe you'd like to make a final comment.
Okay, thank you very much.
Thank you.
Thank you. Thank you.